My name is Sanjay Modi, and I'm actually presenting a case report titled Persistent Hypogammaglobulinemia Despite Replacement Therapy in CVID Secondary to Protein-Losing Enteropathy. So we present an interesting case presentation of a 40-year-old gentleman with a past medical history of B-cell lymphoma status post-R-CHOP and radiation, as well as a recent diagnosis of CVID and recurrent C. diff. He was actually admitted to the ICU for left hip abscess and acinetobacter pneumonia causing overwhelming septic shock. Of note, the patient did have a chronic history of septic arthritis of multiple joints with recent antibiotic use as well as multiple surgeries requiring or causing persistent wounds and serosanguinous drainage from the surgical sites. So, the patient was in the ICU while he was there. He did undergo an IND of the left hip and was started on antibiotics. When he was admitted, his IgG levels were 142, which were low, and he did receive 30 grams of IVIG. His repeat IgG level one day following the IVIG infusion was 565, and 14 days later, it dropped down to 272. His UA was actually showing no nephrotic range proteinuria, as well as his albumin was found to be 1.9, which was low. It was thought due to his recent diagnosis of infectious diarrhea and recurrent C. diff. He was having a protein-losing enteropathy type picture and loss of protein from his serosanguinous drainage from his chronic wounds. Due to his overwhelming multifocal infections, per family's wishes, he was transitioned to comfort care and passed away peacefully. As far as our discussion, we present, a very interesting case presentation of a patient with a known history of CVID, most likely secondary to rituximab therapy, who presented with septic shock due to lack of normal IgG levels after a recent IVIG infusion. And it's thought that the recurrent C. diff created a protein-losing enteropathy due to the persistent infection, as well as protein loss from chronic wounds. There have been notable cases of protein-losing enteropathy, such as celiac disease causing a secondary hypogammaglobulinemia, or exacerbating primary disease processes, such as, in the situation CVID. It is likely that the patient's acute protein drop in IgG 14 days after IVIG infusions may have been due to protein-losing enteropathy secondary to recurrent C. diff, as well as protein loss from the chronic wounds. So in terms of conclusions, secondary hypogammaglobulinemia may occur after rituximab therapy. And this case presentation demonstrates the utility of checking IgG levels prior to rituximab therapy, as there may be worsening immunoglobulin levels post-rituximab therapy. Acute protein loss can exacerbate CVID and cause overwhelming infections leading to septic shock. Therefore, it is important to determine the etiology of acute protein loss early on in the disease process with underlying CVID. In our situation, it was the protein-losing enteropathy as well as the chronic wounds. And if they are reversible, they should be identified early and may improve patients' outcomes. Or, if not reversible, higher dosing of IVIG may be indicated in such settings where there is a rapid decline of immunoglobulin. Thank you for listening.